So my role initially is to introduce the speakers, and I'm going to start with Dr. Wilson Palacios, who hopefully I said that right, who is an associate professor at the School of Criminology and Justice Studies at the University of Massachusetts in Lowell, Massachusetts. He was formerly a professor here at USF. He received his bachelor's, master's, and PhD from the University of Miami in criminology and sociology. And he's done some really interesting research, and a lot of people here know him, but I had already snagged him to talk about his research, so hopefully he'll have time to talk to the people he knows after the session. He's done some really interesting research around drug use disorders in the criminal justice system. He's going to talk about a project that he's currently working on that looks at individuals and community responses to policies that reduce overdose death. And I just want to, my question to him, and you might want to ask him, since I moved in the right direction, I'm wondering why he moved in the wrong direction. Let's welcome Dr. Palacios.
Good morning, everyone. Is this mic working? Yeah? Okay. So the short answer to that question, why I moved in the wrong direction, the heat. No, seriously. It was too hot for my family and I, so we went points north and fell in love with New England. Thank you for inviting me here to spend some time to talk about a national crisis, the opioid syndemic. But before I get into that, I have to be very candid here with everyone that I've been in higher ed for 22 years now, 18 of which, the first 18 was right here at USF in the Department of Criminology. So this is like a coming home for me. So when I was asked by Dr. Lieber if my schedule would allow a visit here to USF in October, I paused for a couple of extra minutes, didn't want to seem too eager, and said, yes, certainly. So, true confession. Thank you, and I want to talk to you about what I call right-sizing the criminal justice system within the current opioid syndemic. And now I want to highlight the word syndemic. A lot of us tend to use the word epidemic, but our preference is to use the word syndemic largely because by using the word syndemic, you're given prominence, you're recognizing that you have to emphasize the social conditions surrounding opioid misuse, abuse, addiction. Social conditions that really intersect and come together when you're looking at developing prevention, intervention, treatment, public safety, and overall public health models. Okay, so all these intersect, and this is why we use the word syndemic. Right. As you see here from the first slide, the Merrimack Valley in Massachusetts has experienced a 5-fold increase in fatal overdoses between the years 2000 and 2017. Massachusetts ranks 7th in the country for overdose rates, and fatal overdose rates above the national rate are ubiquitous across the MA zip codes, as highlighted in these very stark colors. The Merrimack Valley, which is encircled there with the green circle, that's the Merrimack Valley. That's where Lowell is, by the way. The Merrimack Valley is in northeastern Massachusetts, consists of towns and cities along the Merrimack Valley and New Hampshire, including Middlesex County and Hillsborough County, Hillsborough, New Hampshire, that is. It encompasses three post-industrial cities: Lowell, Massachusetts, Nashua, New Hampshire, and Manchester, New Hampshire, which are in proximity to about 21 rural towns. Another stark reality is Lowell is the 15th poorest city in Massachusetts and has experienced decades-long challenges with poverty and disinvestment. And I highlight that because these are examples of what we mean by syndemic. You have to consider these social conditions. It's not just opioids, or you have to consider these social conditions. The Merrimack Valley, another emphasis for syndemic, the Merrimack Valley itself is a hub for heroin and fentanyl distribution to northern New England states, and has been experiencing a high rate of overdose and overdose fatalities. Another reason for using the term syndemic in Massachusetts, especially in the Merrimack Valley, it's very common for local law enforcement to be interdicting pounds, if not tons, of fentanyl off of local law enforcement practices. This is very common, unfortunately, nowadays in the Merrimack Valley. Another reality, another point that we use, why we use the word syndemic, is because recently there was a message put out in social media in Massachusetts. Basically, anyone using illicit drugs in Massachusetts, there's a very high likelihood that fentanyl could be present. And that's a game changer right there. And also recently, fentanyl-laced cocaine could be the next wave of the opioid crisis. And this has been a recurrent theme in the last 4 weeks. And all this has been changing, developing just this year alone. As a result of our reality in Massachusetts, the reality of the opioid syndemic that we're dealing with, having to confront, I bring to you some results from the Rapid Assessment of Consumer Knowledge, RAC. We've collected data, quantitative data and qualitative data across 3 cities. We're funded for another year, RAC 2.0, where we're also exploring novel methods of collecting data. But today I'm just going to focus on the city of Lowell. And by the way, the Rapid Assessment of Consumer Knowledge is a basic public health and community epidemiology surveillance project. This represents the team. This is a multidisciplinary team of folks here, our colleagues from Boston Medical, Boston University, Northeastern University, Tufts University, obviously UMass Lowell, and New England High Intensity Drug Trafficking Agency, part of the Fusion Center. I don't know how many of you are familiar with the Fusion Center, but this has been an initiative, I believe in its 4th or 5th year by HIDA, which they bring in both public safety and epidemiologists working at different fusion centers. I'm happy to say that we have a strong partnership with New England HIDA. The basic goals, to learn from people who use drugs in order to improve programs and policies to prevent overdose. I've always said, even during my time here, if you want to know what's going on, ask people. Ask treatment providers, stakeholders, but ask participants, ask, in this case, consumers. We ask them to describe exposure to, use of, and protective behaviors. What protective behaviors do they employ in this age of fentanyl? We also ask them about what they know in terms of policy, such as the Good Samaritan law that we use in Massachusetts, their knowledge about access to Narcan, and general opioid prescribing medications or medically assisted treatment. And we focus one community at a time. We go in very strategically. The timeline here, as you see, it's as I said before, it's a multi-method, mixed methods approach. A lot of it's, we've spent a lot of time with community outreach, working extensively with the community, which I love. This is what I do. We not only identify partners and stakeholders, but we make sure that whatever data we collect also reflects those immediate needs from those stakeholders in the community. We do ethnographic mapping, environmental scan, we apply geospatial technology, and basic GIS. This is truly multi/mixed methods approach. In terms of recruitment and data collection, we've completed Lowell, the city of Lowell, city of Quincy, and this summer, we were embedded 15 days at the Cape collecting data. I know the Cape sounds glamorous, but it was all work, no play. My friends were envious that I was going to the Cape for 15 days, but it wasn't play. Here's a timeline from September of 2017 to August of 2018, analysis and reporting, and we're currently working on dissemination of findings at the local level. We're first, before any publications are considered or manuscript development, because I know that is the hallmark of any successful project, the first emphasis is on disseminating results to those local communities and working with them first. And then we start writing on the manuscripts. So a little reverse, I would say, but very important that those needs are met first for those in the community. In terms of survey, we collect the basics, usual data points when it comes to survey. We do qualitative one-on-one interviews to do a deeper dive on selected topics. In this study, RAC 1.0 and RAC 2.0, and we hear rumors that there will be a RAC 3.0. All of this does run on Duncan. They do no? I forgot, I'm not in Massachusetts. Okay, I know, Starbucks, I'm sorry, Panera's, sorry. All right, I forgot where I'm at. They get $20 gift cards for both surveys and interviews. Thank you for laughing. So highlights from Lowell. And as you see there, that's where Lowell is within the Merrimack Valley, highlighted for you. And I'm watching careful my timekeeper. Okay, so as far as geographic location, we primarily recruited many of our participants from Middlesex County. As you can see, though, in the visual, we did have some from Suffolk County and Norfolk County as well. When you look at demographics, not surprising, although it might be surprising if you look at the national data. When we recruited at the time, we did a lot of street-based recruitment, younger population, okay? Primarily white, but given the city of Lowell, its general demographics, not too surprisingly. So no surprises there. Homelessness, instability when it comes to having a secure place, right? No surprise there. Many of our participants, and this has been holding true in the other cities and towns that we've been in so far, homelessness is a big issue, as we know, right? If you don't have home first, nothing else matters, right? You can't talk to anybody about treatment or whatnot if they don't feel secure. That's just the reality. And the problems that Massachusetts has with affordable housing is known, and I'm sure many states are struggling with that issue. Special populations, my point is, struggle even more in terms of affordable housing. It seems from the quotes here, and again, this was also a qualitative study. I'm going to throw a lot of quotes at you here, but many of our participants express being caught in a catch-22. In other words, if they, and this is using their words, okay, so pardon me, if they just had a substance use disorder, if they were just addicted to opioids, they don't get any kind of home voucher or vouchers for homes or apartments. However, if they were HIV positive, then they're put on a roster. So what are you telling me? This is their perception, okay? In other words, how sick do I have to be to qualify for assistance for a safe place? In terms of drug use history, no surprise there. For some, I guess, but many of the participants, and again, this has been a trend when we're looking at data from the other cities. Over half of the sample have experienced an overdose. The median lifetime overdose exposure have ranged anywhere, 2 to 50, okay? And the participants who report receiving counterfeit pain pills, about 50%. Other cities have reported more than 50%. In terms of prescription opioid access, consumers are not wasting their time. Because PDMP, the Prescription Drug Monitoring Program, has been so effective, right, in restricting access to pain pills or diversion of pain pills, consumers now, when you talk to them, if they do a quick cost-benefit analysis, it's not worth the risk. Too pricey and too much law enforcement attention. So they've moved away. So this is our reality in Massachusetts. And by the way, this trend has been holding up in other cities. That for us, we don't have a problem, if you will, with pain pills. We do have a counterfeit pain pill problem, of which those counterfeit pain pills are largely adulterated with what? Fentanyl. That's the reality. And, as a nice segue, in terms of fentanyl use, and again, this is a trend that has been holding. Our participants, do report that it's naturally stronger than regular street heroin. Are one of the negative qualities, and this is very important to note, it doesn't have any legs to it. In other words, the euphoria or high, when you compare from a fentanyl-tainted or contaminated heroin experience versus straight heroin, the fentanyl-tainted heroin it has a shorter shelf life, if you will. Thereby, the person has to inject more. And with that, thereby, he or she increases their risk for what? HIV/AIDS, hepatitis C, and other blood-borne pathogens. That's a reality. And that's been consistent in other towns as well. Okay? Again, the participant quotes emphasize what I just said. And in fact, while all of us here can read, I will give you an added bonus to this. It's not uncommon now in Massachusetts when consumers have a toxicology run on them for whatever reason, that they think they were using heroin, but they come back negative for heroin use and they're coming back testing positive for fentanyl. That's a reality. When you look at fentanyl use and the presence of fentanyl along demographics, no surprise if you just look this from a simple younger versus older participants. And what I mean to convey here is that not so much in terms of demographics, meaning age, but younger versus older participants in terms of experience with heroin, okay? Not surprisingly, younger participants, because of their lack of experience with this drug, like and seek out fentanyl, because it's something new to them. It's a much more intense but shorter euphoria, okay? However, our younger participants, because they're younger in their drug using career, have fewer connections and social capital among other participants. So they're not well connected to other social network members. Okay, they have poor opinions about medically assisted treatment or any kind of treatment at all, and have general apathy. Again, not too surprisingly. The older members are complete opposite. Again, reflecting more of where they're at in their drug using career. Might be a point of intervention here. Okay, and the participant quotes reflect this in terms of how they split up in terms of where they're at in drug using career. In terms of navigating fentanyl, because this is our reality, this is our syndemic situation that we have here, fentanyl, when you talk to consumers, they really emphasize community-minded motivations and actually what we call indigenous solutions. In other words, it's very common now, and again, this is a pattern that's holding up across different Massachusetts cities and towns, that when you talk to consumers, they very much employ a test shot, okay, to see if the quality of the heroin is it laced with fentanyl? How much is it laced with, or is it straight heroin? Okay, a lot of our participants carry Narcan and other safety materials with them. In fact, another trend that's been holding up when you talk to our consumers, that many of them have had a history of using Narcan on their friends who have experienced an overdose. And again, I highlight that because that could be a point of intervention when designing programs. They're very much plugged into what works and what doesn't work. And they use it, having the knowledge. This is more of the same. For interest of time, I'm just going to skip over it, but I can definitely talk more about this during the Q&A. In terms of access to Narcan, median number of lifetime witnesses of overdose is 8. The mean was 27. Again, very common. Very easy to get in Massachusetts. People do not have a problem securing Narcan. Okay, it's an awesome way to save a life. It removes the fingerprints of the opioids in the brain long enough to get people breathing and their hearts going again, and to get help to them. Again, very knowledgeable, very knowledgeable. Again, this is a point of intervention when designing programs. Think about the consumers, what they can do peer to peer is what I'm saying. Okay, access again, largely in Massachusetts through pharmacies. But also we have a syringe services programs that do provide access to Narcan and other training, so not an issue in Massachusetts at all. Okay, and again here, the participant quotes just emphasize, that we don't really have an issue in terms of our people accessing Narcan, and they know how to use it, and are free to use it when they have to. Syringe access. So syringe access, sources for acquiring clean syringes, widely available to our participants. This is also a pattern that holds, a trend, if you will, holds across different cities and towns in Massachusetts. The only situation or hurdle is very few accessible locations to publicly dispose syringes. So I'm happy to say that part of what we're working on is to work with city officials in those cities and towns, like with the Parks and Recreation departments, in other areas of public spaces where a lot of drug use does occur in public spaces, and we're working with them in developing a comprehensive syringe discard program, because that's what they need. Okay, and again, out of the interest of time, the quotes here are to support everything I just said, straight from the consumers. HIV, blood-borne virus. Out of the interest of time, I will tell you, and I have a few other slides that emphasize this. You might have heard this. In addition to, again, why we use Syndemic, in addition to fentanyl being our reality, the Merrimack Valley right now is experiencing an HIV/AIDS, hepatitis C outbreak. That's our reality, and here we are. And this reflects this. At the time was a concern, but this is now a reality. Our consumers are very knowledgeable about Good Samaritan law. There is some variability in terms of demographics, okay, in terms of the extent of their knowledge, but they do know about it. Okay. Section 35 is Massachusetts state law that allows persons to request a court order requiring someone to be civilly committed and treated involuntary for alcohol and substance abuse. They're all over the map in terms of Section 35 and its utility in terms of getting them into treatment, or should we be using it. They're all over in terms of medically assisted treatment. The quotes support this. Again, I'm going a little faster here because in the interest of time, I got the 5-minute warning. I don't want to know what happens after that. Access is not an issue. Let me jump to this. Okay, in the less than 2 minutes that I have left. So what's great about this particular project and the other 3 projects that I'm involved in, because they all intersect, right? Recommendations matter and city officials are listening. We have specific harm reduction services recommended or suggested, treatment and recovery, policy, and structural factors. Again, this is all reflecting syndemics. I'm happy to say that just last week, Lowell got its first syringe service program, and that was largely due to this project and other projects that we're working on to help city officials make that a reality. I'm also happy to say that because of these projects are on the ground, the community-based, listening to stakeholders, providers, and consumers, we help design a lot of the public safety messages that have been distributed out to local cities and towns concerning the reality now of cocaine being tainted with fentanyl. And last month, we had several overdose clusters involving marijuana tainted with fentanyl. I know. And we've trained city officials on using Section 35 more efficiently based on what consumers were telling us. And that training has happened. And that's, as you can tell, because I'm animated about it, I'm particularly proud of that. And our reality stands here. We have several projects, and we're submitting several grant applications next year. I got to play that a little close to the vest, but it looks at making headway into understanding why here, why now, in terms of this new HIV, hepatitis C outbreak in the Merrimack Valley, because it's not going to go away anytime soon. Thank you.